Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Fatima Al-Habib from Batch 11 Dental Intern. Today I would like to present my comprehensive case of presentation. My patient is Saudi male, 21 years old. He is student, single and cooperative. The chief complaint of my patient was, I have pain in my upper left tooth. History of chief complaint. The pain started 3 weeks ago and became severe in the last 2 days. The patient does not suffer from any medical illness and no relevant medical history with no past dental history. Oral hygiene activity. He is brushing his teeth once a day. Diet analysis. He consumes 3 main meals per day. Clinical examination including extra and intraoral examination. No abnormalities detected. Pre-treatment photograph, frontal view, maxillary and mandibular view, right and left lateral view. Radiograph, OBG. Actually the case is mainly endo and resto case. You can see the large caries in tooth number 16, 24 and 36 and a lot of proximal caries. You can mention it in right and left bite wing. In posterior region including molar and premolar. Periapical right side, anterior radiograph periapically, periapical left side. Diagnostic cast, frontal view overbite 2 mm. The right overjet is about 2 mm. Canine relationship class 2, molar class 1. Incisor relationship for left side class 1, canine class 2, molar class 1. Maxillary view for mounted diagnostic cast. Mandibular diagnostic cast. Oral hygiene for the patient. Black index according to Saintless and Louis 1.3, which is moderate plaque accumulation. Gingival index about 1.4, which is moderate gingival inflammation. Calculus score, localized slight calculus in lower anterior lingually. Periodontal charting. BSR or sextant is about 1 except the lower anterior. Periodontium diagnosis, generalized moderate plaque induced gingivitis, etiologic and risk factors, black calculus carious teeth. The prognosis is excellent. Coming with the vitality test for tooth number 16, history of the tooth, MO caries, radiographic finding is normal. The cold test with the 16, double positive response. It gives double positive response with vertical and horizontal percussion. It gives also positive response. So the bulb diagnosis is irreversible bulbitis. Periapical is symptomatic apical periodontitis. For tooth number 24, history of the tooth, OD caries, normal radiographic finding. With cold test, it give prolonged pain. With vertical and horizontal percussion, it give also positive response. So bulb diagnosis, irreversible bulbitis. Periapical diagnosis, symptomatic apical periodontitis. For tooth number 36, history of the tooth, MOD caries, normal radiographic finding. It gives prolonged pain with cold test and positive response also with vertical and horizontal percussion. So the bulb diagnosis is irreversible bulbitis. Periapical diagnosis, symptomatic apical periodontitis. Now the treatment plan for periodontal. Oral hygiene instruction, black control, supragingival scaling and polishing, re-evaluation after 4 weeks, maintenance every 6 months. Now I will start the treatment plan tooth by tooth, starting with the impacted teeth 1A, 2A, 3A, 4A. After consultation with the surgeon, he decided to extract all the impacted teeth. For tooth number 17, the dental problem, deep fissure sealant. 16 is reversible bulbitis. The treatment is conventional root canal treatment. 15 distal caries, so class 2 composite restoration. 14 distal incipient caries with occlusal caries, so class 1 composite restoration with the fluoride application. The teeth from 1-3 to 2-3 are sound, so prophylaxis and fluoride application. Tooth number 2-4, reversible bulbitis, proposed treatment, conventional root canal treatment, post, then crown lengthening, then crown. 2-5, MO caries, class 2 composite restoration. 2-6, MO caries with palatal extension, so class 2 composite restoration with palatal extension. 2-7, occlusal pit caries, PRR. 3-7, MO caries with buccal pit, so class 1 composite restoration with buccal pit. 3-6, reversible bulbitis. The proposed treatment it should be conventional root canal treatment, post, then crown lengthening, then crown. 3-5, distal incipient caries with pit caries, so the proposed treatment PRR and fluoride application. 3-4, deep fissure sealant. The teeth from 3-3 to 4-3 are sound, so prophylaxis and fluoride application. Tooth number 4-4, deep fissure sealant. 4-5, distal caries, so class 2 composite restoration. Tooth number 4-6, MOD caries, class 2 composite restoration. 4-7, occlusal with buccal caries, so class 1 with buccal composite restoration. My chosen article for today is about restoration of the endodontically treated tooth. The specific type of restoration required will depend on the position of the tooth in the arch, amount of tooth structure remaining, and the functional demand anticipated, and the overall condition of the dentition. The presence of sound dentin frill is a major factor in the long-term prognosis for a tooth to be crowned. If a crown lengthening will be necessary, the patient informed of the need for surgery prior to the endodontic therapy. What is the frill? Frill is the circumferential ring of the sound tooth structure that is enveloped by the cervical portion of the crown. 1.5 to 2 mm is required between the core and the crown margin. The benefit of the frill is to protect the integrity of the root, to provide bracing or casing action. So the frill is very important major factor. Now the guideline for crown and post placement for posterior teeth. Crown generally required. Molar teeth with an adequate pulp chamber do not require a post. Molar teeth with inadequate pulp chamber may require a post. Above the maxillary bicuspid generally required post because of their small diameter and the presence of high shear stress, while the mandibular bicuspid require independent consideration. Treatment objective: relieve pain, caries control, restore aesthetic and function, improve and maintain good oral hygiene and maintenance. Here is the post-treatment photograph: frontal, maxillary occlusal view, mandibular occlusal view, right and left lateral view. Post-operative radiograph, OBG, bite wing, right preapical radiograph, anterior radiograph, left, and thank you for listening.